Hello Damsonians, welcome to the lecture on the atypical pneumonia. In this lecture we are going to discuss two important topics. One is PCP and we are going to take an overview of tuberculosis. Right. So let's get started. The pneumocystis pneumonia. It was first called as the causative organism. Please remember it occurs only in immunocompromised host. It occurs only in the immunocompromised host. So, in a patient with HIV, it indicates CD4 count less than 200, and that is why PCP is one of the AIDS defining complex. It is one of the AIDS defining complex. It occurs only in immunocompromised host. So what was the causative organism? The causative organism, it was first called as the pneumocystis carinii, but now it is the pneumocystis jeruaki infection. In the humans, it is the pneumocystis jeruaki, which is the causative infection of pneumocystis pneumonia. The causative organism is pneumocystis jeruaki infection. The very important point is the pathology. The pneumocystis jeruaki selectively destroys. It selectively destroys the type 1 pneumocytes. It selectively destroys the type 1 pneumocytes, which leads to the proliferation of the type 2. Proliferation of the type 2 pneumocytes. Type 2 pneumocytes, if you recall, it is similar to the UIP, usual interstitial pneumonia. But the only difference here, the cause is not idiopathic, the cause is infection. The cause is infection, which leads to the proliferation of the type 2 pneumocytes presenting as the interstitial pneumonia. Presenting as the interstitial pneumonia. Presenting as the interstitial pneumonia. That is PCP, pneumocystis carinii, pneumocystis jeruaki associated pneumonia, which can cause infection only in immunocompromised host. Only in the immunocompromised host. It can cause infection. How does it present? Clinical feature. Patient presents with the cough. How? Subacute presentation. Subacute onset of cough is present associated with low-grade fever. Associated with low-grade fever. So it basically presents as a atypical pneumonia. Presents as a atypical pneumonia. It can be, there may be extra the pulmonary symptom also. But in a HIV patient, when they come with subacute cough, low-grade fever, we must think of atypical pneumonia. But classical, on examination, there is paucity of lung sign. There is paucity of lung signs. So patient is breathless, but the patient has got normal examination. Auscultation can be normal. There is no signs. So what are the causes? What are the differential diagnosis in a patient who is having breathlessness? Who is having breathlessness with normal auscultation? What are the differential diagnosis? We must know. This is a very typical finding in clinical examination. Patient is breathless but patient has got normal auscultation. We must consider the differential as metabolic acidosis. Metabolic acidosis, Kussmaul's breathing. It can occur in PCP, pneumonia. It can occur in our next topic, pulmonary thromboembolism. Can occur in the topic pulmonary thromboembolism. So presentation is atypical. Since the diagnosis is delayed, the patient presents with breathlessness. Patient progresses to breathlessness, but the patient has got normal auscultation. Then you think of PCP, acidosis, pulmonary embolism. You think of. But to confirm the disease, what is the gold standard test? You go for bronchoalveolar lavage. Bronchoalveolar lavage to demonstrate the organism. Bronchoalveolar lavage to demonstrate the organism using the two important dyes, that is methamine silver staining or toluidine blue staining. Toluidine blue staining can lead to this problem. Toluidine blue staining can confirm the diagnosis, confirmatory of the diagnosis. So you can see this topic is complete integration. This has to have pathology component, the clinical component, the microbiology component, where the stain is also commonly asked. Once diagnosed, what is the drug of choice? Cotrimoxazole, Septran. The cotrimoxazole is the drug of choice. Septran is the drug of choice. But in a patient who is having, in a case of sulfa allergy, in a case with sulfa allergy, the preferred drug is clindamycin. The preferred drug is clindamycin is preferred. So drug of choice is cotrimoxazole. Along with the sulfa allergy, you can go for clindamycin. Since it is atypical and patient is HIV, the overall prognosis remains poor. Overall prognosis remains poor because patient is immunocompromised. Presentation is atypical, which delays the diagnosis. Treatment is delayed, leading to worse clinical outcome, leading to a poor clinical outcome. This is PCP for you. Number 2, infection that we want to take a overview is the important topic of tuberculosis. We want to take a general overview of tuberculosis, right? So TB is famous topic in our country. It's a common problem in our country, but MCQs are very specific. Let's focus on that. See, the objective of this class is to focus you to prepare for the entrance and give you clinical knowledge. So let us take overview of tuberculosis. The presentation can be broadly divided into two, that is congenital tuberculosis, which is relatively rare, and then there is the acquired tuberculosis or adult tuberculosis, which is more common. Adult TB, which is more common. So we are going to classify patients of tuberculosis into two, congenital tuberculosis and those having acquired or adult tuberculosis. We want to divide them into the two. So congenital TB, when to suspect? The congenital TB should be suspected in the infants of mothers, in the infants of mothers. याद रखिए, सारे इन्फेंट मदर के ही होते हैं, सब में नहीं सस्पेक्ट करना, आगे भी ऐड करो, सस्पेक्टेड इन इन्फेंट्स ऑफ मदर्स हैविंग active tuberculosis, active tuberculosis or receiving anti-tubercular therapy, anti-tubercular therapy during any trimester of pregnancy, during any trimester of the pregnancy. They are suspected in infants of mothers having active tuberculosis or receiving anti-tubercular therapy during any trimester of pregnancy. How does the spread occurs? There is a transplacental spread can occur. The transplacental spread may occur. So if the spread is through the placenta, where it will go to? The primary focus is in the liver. The primary focus is the liver. The placental circulation connects to the liver, the fetal liver. So the bacteria from the mother's blood enters the placenta through umbilical vein of the child into the liver, into the liver. So the primary focus is in the liver in the form of a hepatic granuloma. In the form of a hepatic granuloma is the most common primary focus. But if you look at the clinical feature, granuloma itself most commonly remains asymptomatic. The granuloma remains asymptomatic, and that is why to diagnose congenital TB you need high index of suspicion. You need the high index of suspicion is required. High index of suspicion is required. So whenever you have a child, rather mother will tell you that during the pregnancy I was having tuberculosis. Can you check my child whether they have tuberculosis? That is the common question. So you must suspect the problem, and for diagnosis we need to use the Cantwell's criteria. We need Cantwell's criteria. Any one criteria present can confirm the diagnosis. So any two of the criteria need to be present to confirm congenital TB. What are the Cantwell's criteria say? Number one, what should be done? During the delivery, send the placenta for histopathological examination. If the histopathological examination of the placenta reveals tubercles, histopathology of the placenta reveals the tubercles, that is first criteria. Number two, if it was not done, then do ultrasound shows liver granuloma. Liver granuloma at 1 month of age. At 1 month of age, look for the ultrasound. And number three, you have to exclude other causes. You have to exclude other sources of tuberculosis. Example, in the maids or in the relatives, other household member, the child should not be exposed to. So if they should not have TB, then using the Cantwell's criteria, two or more criteria present can confirm that the child has got congenital TB. Once you diagnose, what is the treatment? The treatment is to give full category 1 anti-tubercular therapy associated with good prognosis. Because till now the disease is restricted to the liver. Child does not have symptom, and if you start it early, the prognosis is good. But what can go wrong? because the symptoms are not there, it is possible that we miss the diagnosis. Possible that we miss the diagnosis, because of which what can happen? If left untreated, if it is left untreated, if it is left untreated at 1 to 2 years age, there can be hematogenous spread of infection can occur. Hematogenous TB spread can occur, and if it occurs, there is a risk of disseminated, also called as miliary tuberculosis. There is a miliary TB risk can occur. So if left untreated at the child when patient does not have symptom, it can lead to dissemination of the infection, and here the patient will be symptomatic. The patient will be symptomatic with anorexia, weight loss, etc. So easy to diagnose. But the treatment at this stage is to again give category 1 anti-tubercular therapy, but prognosis becomes poor. Prognosis becomes poor because now the patient has got disseminated tuberculosis, and the risk of hepatotoxicity is also more with advancing age of the child. So why is the prognosis poor here? Because one, the disease is disseminated to multiple organs, and there is a higher risk of hepatotoxicity, higher risk of hepatotoxicity due to the anti-tubercular drugs, anti-tubercular treatment, making the prognosis poor. So that is why I want every single medical graduate in India to know that congenital TB is a problem in our country, because pregnancy is something which is not predictable always. It is not that many households in our country plan pregnancy. So it can occur that when the person is receiving anti-tubercular treatment, she may become pregnant. Pregnancy once happens, it's considered auspicious. It is considered a good omen. And unfortunately, there are people who will stop the drugs thinking it will affect the child. But they are forgetting the disease itself can affect the child. Not just the medicine, disease itself can affect the child. So if there is a mother who has got TB, when the child is born, send the placenta for checking for tubercles. If you don't do that, do the ultrasound of child at 1 month to look for granuloma. And if either is present and other sources are excluded, then you can say it is a congenital TB and start treatment now. Because if you don't treat now, it will eventually have disseminated tuberculosis with poor prognosis. Which is the poor prognosis? That is important concept of congenital TB. Come to other side. How active or acquired TB is different. Acquired TB is different. How does it spread? India is an endemic country. In endemic countries like ours, endemic country like India, what can happen? More than 85% population, more than 85% population is exposed to TB before 5 years of age. 85% of the population is exposed to tuberculosis before 5 years of age. So what is the mode of transmission? Inhalation route. There is a inhalational spread of tuberculosis in the population, and that is why the primary focus is the Gons focus in the lung. Primary focus is the Gons focus in the lung. The primary focus is the Ghon's focus in the lung. So Ghon's focus does not cause symptom. Does not cause symptom. The TB is limited to the area by the immunity. So the most common cause of adult TB, most common cause of adult TB is reactivation, is the reactivation of the primary focus. Reactivation of the primary focus. Less than 5% are due to contact spread. So remember, most of the TB are actually not because of spreading from other. By 5 years, remember, all of us are harboring TB bacilli. If our immunity goes down, we are at risk of developing tuberculosis. Risk of developing tuberculosis. So common cause is reactivation of the primary focus. And that is why we must have suspicion. What is most common presentation? Most common type is pulmonary tuberculosis. Most common is the pulmonary tuberculosis rather than the extrapulmonary TB. Still, most common remains pulmonary TB, which presents as chronic cough, low-grade fever, anorexia and weight loss. Low-grade fever, anorexia, weight loss. So infection, anorexia, hemoptysis is the presentation in this patient. Presentation in this patient. So if you suspect pulmonary tuberculosis, what are the tests that are available with us? What are the tests that are available with us? What are their sensitivities? And what is the specificity of these tests that we routinely use to diagnose tuberculosis in present day practice? Let's understand that. So pulmonary tuberculosis is the common problem in adult. So what are the tests that we have? Number one, we have got the chest X-ray. Please remember, the chest X-ray is neither sensitive nor specific. We can go for HRCT. The CT scan is better to pick up the infection. So sensitive but still lacks specificity. The radiology cannot tell you difference between active TB, dormant TB. It cannot tell you. So we can take help of other test like the Mantoux test, the tuberculin test, which is the most sensitive test. The Mantoux test or the tuberculin test, which is the most sensitive test in practice, but it is also the least specific, especially in the BCG vaccination. Especially in BCG vaccinated country, the test is useless because after BCG vaccination, Mantoux is going to be positive. Mantoux is going to be positive. So what other test do we have? What other test do we have? We can take help of AFB staining. AFB staining using the Zn stain, Zeal-Nielsen staining, or you can go for AFB culture. You can go for AFB culture. You can go for the AFB staining. If it is positive, is very specific, but it is difficult to detect the organism. The culture is most specific, gold standard, because it is the only test to detect viability of the TB bacilli. The only test for viability of the TB bacilli, but the sensitivity is not good and it takes at least 6 to 8 weeks for culture to come. It takes a long time for culture to come. So what is the problem we are facing? Congenital TB difficult to suspect था, easy to diagnose. Adult TB easy to suspect but difficult to diagnose because radiological test few are sensitive but not specific. Few are specific but not sensitive, making the diagnosis of TB difficult. So for that only we are going to study three important special tests for tuberculosis. We want to make a chart to differentiate three important tests in tuberculosis repeatedly asked: adenosine deaminase, that is ADA levels, adenosine deaminase levels, adenosine deaminase levels, ADA. We have got the TB gold test, the TB gold test, which is also called as the quantiferon gold test, also called as the quantiferon gold test, quantiferon gold test. What it is? It is an interferon gamma assay. An interferon gamma assay in the blood. And we have got the gene expert. We have got the gene expert, which is a nucleic acid amplification test, which is a nucleic acid amplification test using PCR. Amplification test using the polymerase chain reaction. Nucleic acid amplification test using polymerase chain reaction. Three tests I want you to know: adenosine deaminase, TB gold and the gene expert test. एक एक करके प्रैक्टिकल लिखेंगे. Adenosine deaminase. The adenosine deaminase, what it is? It is a lymphocyte degradation product. It is a lymphocyte degradation product. So first remember, ADA is produced by lymphocyte breakdown, not TB bacilli. ADA is produced by lymphocyte breakdown, not TB bacilli. This adenosine deaminase can be tested in which sample? This can be tested in the serous fluids. In the serous fluid sample, it can be tested in only the serous fluid sample. You cannot test it in the sputum. You cannot do ADA in sputum. You cannot do ADA in the blood or the biopsy. It can be tested in the serous fluid sample only. The specificity varies according to the fluid tested. The specificity varies according to the fluid tested. As per the fluid tested, the specificity varies. So in which fluid is it most specific? Most specific in the CSF, followed by the pleural fluid, followed by the ascitic fluid, followed by the ascitic fluid. The sense specificity is variable based on the fluid tested. So what it indicates? Elevated ADA levels. Elevated ADA levels indicate lymphocyte predominant. That's all. It indicates only lymphocyte predominance. It indicates only the lymphocyte predominance. It tells you. Indicates only the lymphocyte predominance. It is going to tell you. Indicates the lymphocyte predominance. It's going to tell you. That means what it is? A surrogate TB marker. It directly does not tell you that it is tuberculosis. It is a surrogate marker of tuberculosis. Surrogate marker of tuberculosis is the ADA, lymphocyte predominance, surrogate marker of tuberculosis. But it is highly sensitive. It is highly sensitivity. So sensitivity is very good of ADA, and as already written, specificity depends on fluid tested. But there are obviously false positive causes because it is not direct marker. What are false positive markers of ADA? False positive, it can be seen in chronic infections, any chronic effusions. Any chronic effusion can lead to false positive. It can be positive in connective tissue disorder, example rheumatoid arthritis, and also in neoplastic effusion. Connective tissue disorder like rheumatoid arthritis or in a neoplastic effusion, it can be false positive also. But advantage is it is very cheap and easily available. It is cheap and easy available. Hence it is good for screening. Making it good for screening. So we can routinely check for ADA level because it is cheap, 250 rupees, and it is available everywhere. So if you do a pleural tapping, do ascitic tapping, do CSF, always ask for ADA level. Always ask for ADA level. In our country, elevated ADA is most commonly associated with tuberculosis, making it a sensitive marker, relatively specific marker, especially in the CSF examination. So double advantage, sensitive and specific marker in the CSF is adenosine deaminase. Come to second column. The TB gold test, quantiferon gold test is the interferon assay. What is the interferon gamma? Interferon gamma is the most potent mediator. Interferon gamma is the most potent mediator of the T cell immunity. Mediator of the T cell immunity against tuberculosis. T cell immunity against tuberculosis, most potent mediator. So interferon gamma is tested. It is a blood test only. It is a blood test only assay. It is a blood test only. That is disadvantage. It is a blood test only where you can do the TB gold test. Blood test only. The good part is what? It has got high sensitivity. It has got very high sensitivity. That is advantage. Almost 100%. So even if there is TB in the body, the interferon gamma will be released by the body. It has got almost 100% sensitivity. The sensitivity is only second best. It is only second best to Mantoux test. Otherwise it is the most sensitive test, and hence it is the preferred screening. Hence it is the preferred screening test in BCG vaccinated population. Preferred screening test in BCG vaccinated population. So in our country, Mantoux test may come positive, but what is alternative you can do? Interferon gamma test in the blood can be used as a good screening test if you are BCG vaccinated individual. But what is the problem? The problem is it lacks specificity. Like Mantoux, it lacks specificity. One. Number two, it cannot differentiate between the active and dormant TB. It cannot differentiate between active and dormant TB, and hence it has limited role. So what we use it, especially the main use in practice, we use it for the screening for tuberculosis, for a international travel visa, international travel for Middle Eastern countries. Before you travel, you need to have a TB free certificate. And for pre-usage, pre-biological use in rheumatology, pre-biological use, example, anti-TNF alpha agent use in rheumatology. In rheumatology, we want to check for the screening, because the biological use TNF alpha increases risk of the TB reactivation in rheumatology disorder, to exclude dormant TB, to exclude dormant tuberculosis we want to do. So we can use interferon gamma assay. We can do blood test. It's called quantiferon gold, TB gold test. On the other side, last column, we have got the gene expert. So what is advantage? Gene expert uses the nucleic acid amplification using polymerase chain reaction. It selectively amplifies. It amplifies the genes specific to TB. It amplifies genes or the nucleic acid specific to MTB, mycobacterial tuberculosis, and that is why it is specific. That is why it is going to be specific. Advantage: gene expert can be used for serous effusion sample, can be tested in serous effusion sample. You can test it in the sputum. You can test it in the biopsy sample also. You can test it in the biopsy sample also. That is good advantage. It has got high sensitivity. It has got high sensitivity with high specificity. Both are present. High sensitivity and high specificity, both are present. It also gives you the result within the 2 hours. It can also detect rifampicin resistance. It can also detect rifampicin resistance can be detected. So it has got multiple advantages. But फिर भी AFB culture we have written as gold standard. Why? But it is not the gold standard. It is not the gold standard because it cannot check, it cannot confirm the viability of the TB bacilli. The viability of the TB bacilli. It is only detecting the genes, the nucleic acid. It cannot tell you. So dead bacilli also can come as test positive. That can come as test positive. But it has got multiple advantages, and hence it is available free of cost. Available free of cost under the DOTS Plus program. It is available free of cost under the DOTS Plus program. And what we use it for? It is mainly to screen for. It is mainly to screen for MDR TB in a patient with recurrence. in a patient with relapse or in a patient with immunocompromised host. Immunocompromised host, I can check for rifampicin resistance and use it for early detection of MDR-TB. Early detection of MDR-TB, I can use it for. So this is a very practical point that we have to learn in the modern test for tuberculosis, modern test available for tuberculosis. The treatment of tuberculosis RNTCP program, please refer to PSM. Just follow the guidelines. According to the latest PSM guidelines, you are covering that you have to continue RNTCP guideline. You will follow. So in medicine, our focus is on suspecting TB, diagnostic test of TB. Then you follow the program. You follow the category 1, category 2, MDR TB, XDR TB treatment you want to offer. Right? So this is TB for you. Atypical pneumonia in this session. Right. Join me for next video on the complication, the most dreaded lung disease, that is ARDS.